Today, we're really getting into the weeds on one of the most complex and I think one of the most beautiful pieces of biological machinery, the wrist and hand.
Absolutely. I mean, forget the sort of high-level diagrams you might remember from a biology class. We're going to peel back every single layer. We want to understand the mechanics, the networks, the sheer engineering that makes human movement, human dexterity possible.
Exactly. It's the very definition of our species' ability to interact with the world.
When you stop and consider the precision needed for, I don't know, anything from a surgeon making an incision to just you fastening a button on your shirt.
Yeah.
It all comes down to this incredible synchronization of 27 small bones, dozens of muscles, and these intricate neural and vascular pathways.
It's a symphony.
It really is. So for you listening, our mission today is to move past just listing anatomical parts. We want to get into the biomechanical why. How does this machine work so perfectly? How does it achieve this incredible leveraged efficiency?
And we're going to do it layer by layer. We're going to start right at the surface with the skin and move meticulously through the stabilizing fascia, the complex skeleton, the engine of the muscles, and then finally the supply lines that keep it all running. It's really an appreciation of the ultimate precision machine.
Okay, so where else to start but the surface? Superficial envelope. And even here, with just the skin of a hand, it's not simple. It's highly specialized.
It is. The second you look at your own hand, you see this profound contrast, this functional dichotomy between the back of the hand, the dorsum, and the palm.
They feel completely different.
And they're designed to be. The dorsal skin on the back of your hand, it's thin, it's quite lax, and it's very mobile.
You can pinch it and pull it up easily.
You can, and it has to be that way. It needs to be able to stretch and slide a huge amount, especially when you make a tight fist. Think about it. The skin has to travel over those knuckles.
Right. The tendons underneath are moving, and the skin has to accommodate that.
Exactly. It can't restrict them. That mobility, by the way, is also why the back of your hand swells up so easily after you bang it on something. There's just more loose space for fluid to accumulate.
And it's also where you have hair, fewer nerve endings. It's not the business end of the hand, so to speak.
Not at all. The palm is the business end. The palmar skin is a completely different world. It's a specialized gripping surface. It is incredibly thick, rugged, and completely hairless.
And packed with glands and nerve.
Packed. It's dense with sweat glands, which is essential for grip and thermoregulation. And critically, it possesses one of the highest densities of sensory nerve endings in the entire body. It's your primary interface for tactile information.
But the real game changer, the thing that makes it all work, is how it's attached, right?
That is the crucial difference. It's all about the tethering. The palmar skin is firmly, and I mean firmly, anchored to the deep fascia underneath it, specifically the palmar aponeurosis.
How is it anchored?
By thousands of tiny, vertical fibrous strands. They act like nails, pinning the skin down. And this means the palmar skin cannot slide around when you grip something.
Which is everything. If it could slide, you'd never be able to hold on to anything securely.
You'd have zero precision. The slightest force would cause the skin to slip, and your grip would fail. That stability is paramount.
That tethering is the perfect lead-in to the flexure creases, the lines on your palm. Most people just think of them as wrinkles.
Yeah, just random folds.
But they're not random at all, are they? They are very precise anatomical markers.
They're engineering points. They show you exactly where the skin is anchored most firmly to the deep structures. They're far more than cosmetic.
So what's their mechanical purpose?
They allow the skin to bunch up in a controlled way when you flex your joints, and they prevent it from getting stretched too tightly when you extend them. They're like pre-planned folding zones.
Okay, let's break them down, starting at the wrist.
At the wrist, you'll typically see three main creases, the proximal, middle, and distal wrist creases. The proximal one, the one closest to your forearm, that really marks the actual start of wrist joint movement.
And the distal one?
The distal crease is a really important landmark because it often aligns with the top edge, the proximal boundary of the flexor retinaculum, which we'll get to.
So surgeons would use that as a guide?
Absolutely. Now, moving into the palm itself, the creases are even more critical. You have the really dominant lines like the thenar crease.
The one that curves around the base of the thumb?
Exactly. And that line perfectly outlines the range of motion of the thumb's unique joint, the CMC joint. It shows you how far that thumb can swing across the palm.
Then you have the ones that cut across the middle of the palm.
Right, the proximal, intermediate, and distal palmar creases. The two more distal ones really define the functional boundaries of that central fascial complex, that palmar aponeurosis we mentioned. Again, critical surgical landmarks.
And then finally down on the fingers themselves, the digital creases.
We have 3 sets there, corresponding to the joints. The proximal, middle, and distal interphalangeal creases.
So one for each knuckle joint.
Essentially, yes, though there's a fascinating little detail. The proximal digital crease, the one at the very base of the finger, is often a double crease, and it actually lies a little bit proximal to the true joint line. It's closer to the web space of your fingers.
Oh, interesting. So it's not directly over the joint.
Not directly, but the middle crease is right over the middle knuckle, the PIP joint, and the distal crease is right over the end knuckle, the DIP joint. They're very reliable markers for the joint underneath.
And the thumb is a bit different, having only 2.
2 phalanges, so 2 main creases crossing its joints. One for the MCP joint at the base and one for the IP joint further up.
And within that palmar skin, we can't forget about fingerprints, the friction ridges.
Right, a totally unique feature. These are specialized epidermal projections, mostly on the pads of your fingertips. Their sole purpose is to increase the coefficient of friction.
To help you grip.
To help you grip, especially on smooth or wet surfaces. They're like the treads on a tire.
Okay, so moving just a fraction of a millimeter deeper, beneath this incredible skin, we find the cutaneous vascular supply, the plumbing.
The plumbing for the skin itself, and it's a dense superficial network. On the palm, the blood comes from small branches of the radial and ulnar arteries. On the back, from the dorsal carpal network. It's a really rich plexus of vessels, which makes sense given how metabolically active and important that palmar skin is.
The veins, though, are much more obvious, especially on the back of the hand. And they're clinically very important.
Incredibly important. The drainage system is organized into what we call the dorsal venous network. You can see it on your own hand right now.
The blue lines on the back of your hand.
Those are it. It starts with tiny dorsal digital veins from the fingers, which merge to form the dorsal metacarpal veins. And those, in turn, drain into the 2 big superficial veins you see running up your arm.
The cephalic and the basilic.
Exactly. The cephalic vein on the thumb side, the basilic on the pinky side, and this network is precisely where IV lines are so often placed.
Like there.
Because the veins are big, they're easy to see, and they're very mobile under that loose dorsal skin. It makes them easy to access.
This level of detail in the soft tissue is so critical when you start looking at specific types of injuries. Let's take a moment to understand a really nasty one. Ring avulsion injury.
Yes. It's a fascinating and devastating mechanism.
What's so interesting is that it's not a crush injury. It's not about compression. It's a pure longitudinal stripping force.
So a ring gets caught on something.
A fence, a piece of machinery,
Yeah.
and your body keeps moving. All that force is suddenly applied along the axis of the finger. And because the ring itself is unyielding, it acts like a circular guillotine.
And it just strips everything off.
It strips the soft tissues, the skin, the fat, and critically, the tightly packed neurovascular bundles right away from the bone. It's a degloving injury, and often the bone itself isn't even fractured. Wow. And the severity is classified based on what happens to that plumbing, to the vascular system.
Entirely. Class 1 is the best case scenario, if you can call it that. The tissue is torn, but the blood supply, the arteries and veins, they remain intact. The finger is still viable.
So that's repairable.
Repairable, yes. It requires careful tissue repair, but the digit can be saved. Class 2 is where the blood flow is compromised or completely interrupted. The arteries and veins are torn.
Which is an emergency.
A true surgical emergency. This requires immediate microvascular surgery to go in and painstakingly repair those tiny torn vessels to try and revascularize and save the digit.
And then there's the most catastrophic level.
Class 3, that's a complete avulsion. The finger and ring are torn completely off, or the stripping is so extensive that the blood supply is just gone. It can't be recovered.
Requiring amputation.
Inevitably. The initial force is so violent that everything, skin, nerves, arteries, veins, is violently separated from the bone. It's a brutal illustration of just how tightly packaged those neurovascular bundles are running along the sides of the phalanges and just how vulnerable they are to that specific type of shear force.
Okay, so we've established the specialized surface. Now we need to move deeper into the architecture, the stabilizing and channeling elements, the fascia and the retinaculum.
This is the scaffolding. These structures are what guide movement and really what prevent chaos inside the hand.
And the absolute centerpiece of this architecture at the wrist has to be the flexor retinaculum.
Also known as the transverse carpal ligament. You can't overstate its importance. It is a dense, thick, unyielding band of deep fascia that has one singular essential biomechanical job.
And that job is to create the most famous, or maybe infamous, anatomical bottleneck in the entire upper limb.
That's a perfect way to put it. You see, the carpal bones themselves form this deep U-shaped arch. The retinaculum stretches tautly across the top of that U,
turning the U into an O.
Exactly. It converts that open concave arch into a closed, protective, fibro-osseous tunnel, the carpal tunnel.
And to really understand how rigid and unyielding this space is, we need to look at its attachments. Where does it lock in?
It's anchored to bone on both sides. Medially, on the pinky side, it locks onto the pisiform bone and the hook of the hanete.
Okay.
Laterally, on the thumb side, it attaches to the scaphoid tubercle and the ridge of the trapezium. So it's stretched between 4 solid bone pillars. It doesn't give.
It's a tight, fixed ceiling over this bony floor. And when you think about what has to squeeze through there, it's just amazing that it works at all.
It's an incredible squeeze. There are exactly 10 structures that have to pass deep to this ligament. 9 of them are the long flexor tendons.
9 tendons? Yep.
The 4 tendons of the flexor digitorum superficialis, the 4 tendons of the flexor digitorum profundus, and the single tendon of the flexor pollicis longus.
And the 10th structure.
Yeah.
The one that causes all the trouble.
The 10th, and by far the most clinically sensitive structure, is the median nerve.
The second you describe that incredibly confined space, my brain just screams carpal tunnel syndrome.
Of course, because CTS is fundamentally a pathology of volume. It's a real estate problem.
Too much stuff, not enough space.
Precisely. The tunnel is a fixed volume. So any condition that increases the volume of the contents inside, like inflammation of the synovial sheaths around those 9 tendons, what we call tenosynovitis.
Or fluid retention from pregnancy or trauma.
Exactly. Or even certain endocrine disorders like myxoedema. Anything that adds volume reduces the available space. And the tendons can actually tolerate a bit of compression. The median nerve cannot.
Why is the nerve so much more vulnerable in there?
Well, a few reasons. First, it doesn't have the same tough protective outer layer, the epineurium, that peripheral nerves have elsewhere. It's a bit more exposed. But more importantly, chronic compression physically impedes the microcirculation, the tiny blood vessels within the nerve itself.
It cuts off its own blood supply.
It leads to ischemia. And a nerve without blood is a nerve that can't function. And that manifests as the classic symptoms: pain, burning, tingling paresthesia that's often worse at night.
And that affects the thumb, index, middle, and half of the ring finger.
The exact sensory distribution of the median nerve. And if it goes on long enough, it progresses from sensory problems to motor weakness and eventually to visible wasting of the thumb muscles. It's a slow, insidious, mechanical strangulation of that nerve.
So, moving distally from the carpal tunnel out into the hand itself, we encounter this incredibly robust layer called the palmar fascia complex.
Right, and the centerpiece of that is the palmar aponeurosis.
This is that tough, gristly stuff in the middle of your palm.
It is. It's a thick, central, triangular sheet of deep fascia, and it's structured like a fan to maximize strength and distribute forces across the palm.
Where does it anchor?
Proximally, it's firmly attached to the flexor retinaculum, and it often receives the tendon of the palmaris longus muscle, if you have one.
The muscle that about 15% of people are missing.
That's the one. Then, distally, it fans out and divides into 4 distinct slips that travel out to the roots of the forefingers.
And those slips, I understand, are more than just attachments. They actually help divide up the palm.
They do. As they travel distally, they send these vertical extensions, like walls, diving deep down into the hand. These are the vertical fibrous septa.
And they create compartments.
They create 3 main, functionally separate fascial compartments. There's the lateral, or the fanar compartment for the thumb muscles, the medial, or hypothenar compartment for the little finger muscles, and then the big central compartment, which houses the long flexor tendons, the vessels, and the nerves passing through.
So, to crystallize that thought, that tethering we talked about with the skin gives you grip stability, and this deeper compartmentalization is vital for things like infection control.
That's exactly it. These septa act as physical barriers. If you get a deep infection, say from a puncture wound or an infected tendon sheath in that central compartment, the pus accumulation is usually contained.
It can't just spread everywhere.
Right. It has a much harder time spreading into the thenar or hypothenar spaces, or tracking up into the forearm. And that's hugely important for a surgeon planning how to drain that infection. It dictates the entire approach.
Okay, and running deep to all of this, providing some side-to-side stability for the hand itself, is the deep transverse metacarpal ligament.
The DTML. It's a powerful, band-like ligament that essentially ties the heads of the 4 medial metacarpals together, the ones for your index, middle, ring, and little fingers.
It connects the knuckles deep down.
It does. It links them functionally and helps maintain the transverse arch of your hand, which is critical during a power grip. It's the deep anchor point for many of those fibrous septa we just talked about. Without the DTML, when you squeezed hard, the heads of your metacarpals would just splay apart and your grip would be incredibly unstable.
All this fascia and all these septa, they create these potential spaces. Spaces that aren't really there until something like pus fills them up.
That's a perfect description. They are potential spaces that become real clinical problems. The 2 major ones in the palm are the thenar space and the mid-palmar space.
Where are they located specifically?
The thenar space is on the thumb side, located between the central tendon compartment and the adductor pollicis muscle of the thumb. The mid-palmar space is the bigger one, in the center, lying deep to all the long flexor tendons right on top of the metacarpal bones.
And these are the danger zones for infection.
They are. Because they are deep, and they are the primary sites where pus from a serious hand infection will accumulate. Draining them properly requires a very specific surgical approach.
Now, before we leave the fascia, we have to talk about the other crucial tunnel in the wrist, one that's anatomically totally distinct from the carpal tunnel.
Guillen's canal.
Guillen's canal.
Also called the ulnar canal. It's located on the ulnar side, the pinky side of the wrist. It's much smaller and more superficial than the carpal tunnel.
What are its boundaries? What makes the tunnel?
The floor is formed by the flexor retinaculum and the pisiform bone. The roof is formed by the palmar fascia and a tiny muscle called the palmaris brevis. So it's another one of these fiber osseous tunnels.
And what passes through this smaller canal?
Only 2 key structures, the ulnar nerve and the ulnar artery.
So any compression here is going to affect a totally different set of structures than in carpal tunnel syndrome.
Completely different. Because the canal is superficial, it's vulnerable to compression from, say, repetitive trauma like a cyclist leaning on their handlebars for hours.
Handlebar palsy, they call it.
Exactly. Or a mass, like a ganglion cyst, or even a fracture of the hook of the hamate, which forms one of its walls. Any of those can compress the ulnar nerve specifically.
And the symptoms would be completely distinct from CTS.
Totally. You get motor weakness in almost all of the small intrinsic muscles of the hand, the interossei, the hypothenar muscles, and sensory loss exclusively in the pinky and half of the ring finger.
And crucially, the muscles in the forearm that are supplied by the ulnar nerve would be fine.
They'd be spared because the branches to those muscles, like the flexor cupiulnaris, come off way higher up the arm. So it allows a clinician to pinpoint the location of the compression right to that little canal at the wrist.
Okay. We have stripped away the skin, the fascia. We have finally reached the foundation, the skeleton. 27 bones forming this mobile, resilient framework. This is where the complexity really begins.
It is. We start with the carpus, the wrist itself, which is comprised of 8 small carpal bones, and they're arranged in 2 very distinct rows of 4.
And they don't just sit there. They form this flexible compound arch that's dynamically adjustable.
It's not a rigid structure at all. Let's start with that proximal row, the 4 bones that actually articulate with the forearm.
Okay, starting on the thumb side.
We have the scaphoid. It's the largest bone in the proximal row. It's sort of boat-shaped, and you can feel its little tuberosity on your wrist. It's absolutely critical because it functionally links the 2 carpal rows together.
But it has a notorious problem with its blood supply.
It has a terrible blood supply. It's retrograde, meaning the blood flows from distal to proximal. So if you fracture the scaphoid, especially through its narrow waist, the proximal fragment can be cut off from its blood supply,
leading to a vascular necrosis.
The bone dies. It's a huge complication and why scaphoid fractures are taken so seriously.
Okay, next to it, the lunate.
The lunate is crescent-shaped, hence the name. It sits right in the center and articulates extensively with the radius. It's a key player in load bearing.
And it's prone to dislocation.
Notoriously so. A bad fall on an outstretched hand can pop it forward right into the carpal tunnel. And that is a surgical emergency because it will immediately compress the median nerve and all those tendons.
Then we have the triquetrum.
The triquetrum is pyramid-shaped. It articulates with the lunate and the hamate. But importantly, it doesn't articulate directly with the ulna bone.
Right. There's something in between.
The triangular fibrocartilage complex, or TFCC. It's a little cartilaginous disc that acts as a cushion and allows the wrist to move without being constrained by the ulna.
And the smallest bone in that row, the pisiform.
The pisiform is unique. It's a sesamoid bone.
Meaning it's embedded within a tendon.
Exactly. It's embedded within the tendon of the flexor carpi ulnaris muscle. And this is a pure biomechanical adaptation. It's an engineering trick.
How so?
By sitting within the tendon, it acts as a spacer. It pushes the tendon's line of action further away from the axis of rotation of the wrist. In physics terms, it significantly increases the moment arm of that muscle.
Which makes it much more powerful.
Far more efficient. It gives the muscle better leverage, making it a much stronger wrist flexor and ulnar deviator than it would be otherwise. It's the same principle as the kneecap.
Brilliant. Okay, that's the proximal row. Now for the distal row, the four that articulate with the hand itself.
Again, starting on the thumb side, we have the trapezium. It's got a little tubercle and a groove, but its entire structure is dictated by its articulation with the thumb's metacarpal. It has a very special saddle-shaped surface,
Which we will definitely come back to next to it.
the tiny trapezoid. It's small, wedge-shaped, and it fits snugly between the trapezium and the capitate. It's one of the most stable and least mobile carpal bones.
Then the big one in the middle, the capitate.
The capitate is the largest carpal bone of all, and it truly is the keystone of the distal carpal arch. It's the central pillar. Its big, rounded head fits into the concavity formed by the scaphoid and lunate. All the other carpal bones really rotate around the capitate during flexion and extension.
And finally, on the pinky side, the hamate.
The hamate is wedge-shaped, but it's distinguished by one very prominent feature.
The hook of the hamate.
The hook. It's this bony projection that you can actually feel if you press deep into your palm on the pinky side. And as we've said, it's a vital attachment site for the flexor retinaculum. It forms a wall of Goyen's canal, and it's an origin point for some of the little finger muscles.
Oh, it can break.
It can. Fractures of the hook are common in sports where you swing something golf, baseball, tennis from the impact, and a fracture there can directly irritate the ulnar nerve running right past it in Goyen's canal.
Let's touch on ossification briefly. These bones don't start out as bone.
Not at all. Carpal ossification starts remarkably late, only after birth. The capitate and hamate are usually the first to start turning to bone in the first few months of life.
And the process takes years.
It's very lengthy, continuing right through the teenage years. The pisiform, being a sesamoid bone, is always the very last one to ossify. Sometimes it doesn't show up on an X-ray until a child is 12 years old. This delayed hardening keeps the hand and wrist somewhat pliable and adaptable during early growth.
Okay, distal to the carpus, we have the 5 metacarpals, which form the architectural span of the palm.
Right. And
Wow.
each one has a pretty clear structure. A base, which articulates with the carpals, a long shaft, which has a slate palmar curve to it to accommodate the tendons, and then a rounded head, which forms the knuckle.
But the first metacarpal, the thumb's metacarpal, is a complete outlier. It redefines the whole system.
It absolutely does. It's shorter, it's broader, it's much more robust than the others. And as we mentioned, its base forms that incredibly specialized saddle joint with the trapezium.
And that's what allows its extreme mobility.
Extreme mobility. Crucially, the first metacarpal can undergo independent rotation along its long axis. And it's that rotation combined with abduction and flexion that results in true opposition.
So without that little bit of built-in twist, you couldn't touch your thumb to your fingertips.
You could bring it across the palm, but you couldn't get that pad-to-pad precision. That rotation is the secret sauce.
Meanwhile, the other 4 metacarpals are more like stable pillars.
For the most part, the second and third metacarpals for the index and middle fingers are very rigidly fixed at their bases. They form this highly stable central pillar of the hand.
Which you need for tasks like writing or pushing.
You need a fixed platform. But the fourth and fifth metacarpals are actually slightly more mobile. They have a little bit of movement at their base.
Why? What's the advantage of that?
It's essential for the cupping action of the palm. That a little bit of extra flexion and movement in the fourth and fifth metacarpals is what allows you to wrap your hand effectively around a cylindrical object like a baseball bat or a jar. It deepens the palm's hollow.
And finally, the phalanges, the 14 bones of the digits themselves.
3 for each finger proximal, middle, and distal, and 2 for the thumb. Their structure is perfectly tailored for movement. The palmar surface of the shafts even has little grooves and ridges to accommodate the fibrous tunnels of the flexor tendon sheaths.
So the bones are literally shaped to guide the tendons.
They are. And the dorsal surfaces are a bit rougher for the attachment of the extensor mechanism. Every detail has a purpose.
The wrist isn't just one joint. It's this system of joints working in perfect, synchronized harmony. Let's start with the big one, the radiocarpal joint.
Right, this is the primary joint. It's a synovial biaxial joint. It's formed by the distal end of the radius articulating with that proximal row of carpal bones.
Specifically, the scaphoid, lunate, and trichotrum.
Correct. And if we connect this to the bigger picture, the other forearm bone, the ulna, is deliberately excluded from this joint.
Why? Why isn't it a three-bone joint?
That exclusion is critical for function. The ulna is separated from the carpus by that TFCC we mentioned. This allows the radius, which is holding the hand, to rotate around the ulna during pronation and supination,
Turning your palm up and down.
without transmitting those big rotational forces directly into the small, sensitive carpal bones. It decouples forearm rotation from wrist movement, which is mechanically brilliant.
And here's where it gets really interesting, the actual movements. The range of motion is huge.
It is. The wrist can flex up to 85 degrees and extend or bend back up to 90 degrees. It can also deviate side to side.
But not equally.
Not equally at all. Ulnar deviation, moving your hand towards your pinky, is much greater, up to 45 degrees. Radial deviation towards your thumb is much less, maybe 20 degrees.
And there's a simple bony reason for that.
A very simple reason. The radial styloid process, that pointy bit of bone on the thumb side of your wrist, projects much further down than the ulnar styloid. It physically blocks the movement sooner. It's a bony block.
But the true functional magic relies on the movement that happens at the next joint down, the midcarpal joint.
The midcarpal joint is this complex S-shaped articulation between the proximal and distal carpal rows. It's not an independent joint. It acts as an intercalated segment. It moves in concert with the radiocarpal joint.
So the total movement of the wrist is split between these two joints.
It's split. Roughly speaking, about 60% of flexion happens at the midcarpal joint, and about 40% of extension happens there, with the inverse happening at the radiocarpal joint. This synchronized reciprocal gliding is what makes wrist movement so smooth and so resilient to stress.
This architecture also dictates how forces are transmitted. When you lean on your hand, where does the weight go?
The load distribution is very specific. About 80% of the axial load, the force coming off your arm, is transmitted through the radiocarpal joint. It goes through the scaphoid and lunate directly to the radius.
Only 80%. Where does the other 20 go?
The remaining 20% is transmitted through the TFCC to the ulna. This massive disparity confirms that the radius is the primary weight-bearing bone in the forearm, which is why it's so much bigger at the wrist than the ulna is.
When this beautiful synchronized motion breaks down, that's when you get carpal instability.
Carpal instability is what happens when you damage the ligaments that hold these carpal bones in their precise alignment. The most commonly injured one is the scapholunate ligament, which ties the scaphoid and lunate together.
And when that tears, they lose their connection.
They lose their mechanical coupling, the carpal rows lose their rotational control, and the bones fall into a predictable pattern of malalignment. The scaphoid rotates forward, the lunate rotates backward, a pattern called DSI, or dorsal intercalated segment instability.
This raises a really important question. How much functional deficit does even a minor bit of carpal instability create?
The deficit is disproportionately huge. It's massive, because the wrist relies entirely on this precise sequential gliding. Even a few degrees of abnormal rotation, something that might look subtle on an X-ray, creates enormous uneven pressure points on the articular cartilage.
So it's grinding itself away.
It's grinding itself away. It immediately disrupts the smooth, shock-absorbing kinematics. This leads to pain, a significant loss of grip strength, and inevitably progressive degenerative arthritis. The dynamic stability is gone.
Moving from the wrist into the hand proper, let's revisit the carpometacarpal joints, the CMCs.
The star of the show, without a doubt, is the thumb CMC joint. The articulation between the trapezium and the base of the first metacarpal.
And its saddle joint configuration is the whole secret.
It is the mechanical secret to the thumb's versatility. One surface is concave in one direction and convex in the other, and they fit together perfectly.
And that shape allows.
It allows movement in two full planes: flexion extension and abduction adduction. Plus that critical bit of axial rotation we talked about. And opposition is the beautiful cumulative result of all those movements happening at once. It's what sets our hands apart.
The other CMC joints, for the fingers, are the anchors.
They are. They're primarily plane joints with much less movement. The second and third CMCs are virtually immobile. They form that rigid central column. But the fourth and fifth are, as we said, slightly mobile. Just a few millimeters of gliding and rotation.
Which is just enough for that cupping motion.
Just enough. It's a tiny amount of movement with a huge functional payoff.
Okay, next up, the metacarpophalangeal joints, the MCPs, the knuckles.
These are condyloid joints, which allows for movement in two axes, flexion and extension, but also abduction and adduction, spreading your fingers apart and bringing them together.
And the really critical anatomical detail here is the behavior of the collateral ligaments on the sides of these joints.
Yes, this is so important clinically. The collateral ligaments of the MCP joints are eccentric. They're attached in a way that makes them relaxed and lax when the joint is straight, in full extension.
Which allows you to spread your fingers.
Exactly. But because of the shape of the metacarpal head, which is wider on the palmar side, those same ligaments become maximally taut and tight when you make a fist, when you move the finger into flexion.
And why is that so clinically critical?
Because if you have a hand injury and you immobilize the hand with the MCP joints straight, in extension, those lax collateral ligaments will shorten and scar down. And the patient may never be able to fully make a fist again.
So you have to splint them in flexion.
You often splint them in what's called the safe position or intrinsic plus position, with the MCP joints held in about 70 degrees of flexion to keep those ligaments at their maximal length while they heal.
Fascinating. And lastly, the interphalangeal joints, the PIPs and DIPs. The knuckles and the fingers.
These are much simpler. They are pure hinge joints. Movement is strictly limited to flexion and extension. That's it. It maximizes power and stability for gripping. They're heavily stabilized by strong collateral ligaments and a structure on the palmar side called the volar plate, which prevents them from hyperextending.
The skeleton provides the levers, but the engine is the muscle system. And it's really a story of two different types of muscles.
It is. You have the powerful, volume-driven extrinsic muscles, which have their muscle bellies up in the forearm.
And their long tendons run down into the hand.
Right. And then you have the small, detail-oriented, precision-focused intrinsic muscles, which are located entirely within the hand itself.
Let's start with the extrinsics, the power from the forearm, the long flexor tendons.
These generate the gross power for your grip. You have the flexor digitorum superficialis, or FDS, which primarily flexes the middle knuckle, the PIP joint.
Okay.
And then running deeper to that is the flexor digitorum profundus, or FDP. And this is the only muscle that is capable of flexing the end joint of your finger, the DIP joint.
And both of their tendons, plus the thumb flexor, all have to pass through the carpal tunnel.
All 9 of them packed in there together.
And as they travel through this high-friction environment, they need lubrication. That's the role of the synovial sheaths.
Right. The synovial sheaths are these specialized linings that secrete a lubricating fluid, allowing the tendons to glide almost frictionlessly inside these tight, fibrous tunnels.
And they're organized in a specific way.
They are. The 8 FDS and FDP tendons share a big common sheath as they pass through the carpal tunnel. We often call it the ulnar bursa. The thumb's flexor tendon, the FPL, has its own separate sheath, the radial bursa.
And we absolutely must detail the continuity of these sheaths because it has huge implications for the spread of infection.
It's critical. The sheath for the little finger is very often continuous with that common flexor sheath, the ulnar bursa.
What does that mean practically?
It means if you get an infection in the little finger's tendon sheath, that infection can track directly from the fingertip all the way down into the central palm and right up into the wrist through the carpal tunnel. It creates a horseshoe abscess.
That sounds dangerous.
It's very dangerous. Whereas the sheaths for the index, middle, and ring fingers are usually separate. They end proximally in the palm, so an infection in one of them tends to stay localized to that finger.
Wow. All because of a slight difference in anatomy. Now, we get to what I think is a masterpiece of biomechanical engineering, the crucial pulley system.
It is an absolute masterpiece. As the flexor tendons run down the fingers, they are held tightly against the bone by a series of fibrous tunnels, which are reinforced by these incredibly strong, thickened fibrous loops called pulleys.
And they have names, annular and cruciate.
Annular or A pulleys are like thick rings. Cruciate or C pulleys are thinner and crisscrossed.
And their job is more than just holding the tendon down.
Their fundamental role is to maintain the moment arm of the flexor tendons. They prevent something called bowstring.
Like a bow and arrow.
Exactly like that. When you flex your finger, the tendon wants to take the shortest path, to pull away from the bone like a drawn bowstring. The pulleys prevent that. They hold it flush against the phalanges.
And if they didn't, if the tendon lifted away,
The effective distance between the joint's axis and the tendon's line of pull would be dramatically reduced. The force generated by your muscle would translate into significantly less rotational movement at the joint. Your grip strength would plummet.
Which specific pulleys are the most important?
They're all important, but the A2 pulley, which is over the proximal phalanx, and the A4 pulley over the middle phalanx are by far the most critical for maintaining mechanical efficiency. The A1 pulley, right at the base of the finger over the MCP joint, is also clinically famous.
Why is that one famous?
Because inflammation and thickening there is the cause of trigger finger. The tendon develops a little nodule that then gets caught as it tries to pass through that narrowed A1 pulley opening, causing that characteristic clicking or locking.
And if we connect this to the bigger picture, a climber who ruptures an A2 or A4 pulley has a major problem.
It's a catastrophic injury for a climber. A rupture of one of those critical pulleys can reduce your maximal grip strength in that finger by 30% or more instantly. The powerful forearm muscles become totally inefficient.
Okay, let's flip over to the back of the hand. The extensor tendons. They pass under the extensor retinaculum in 6 neat compartments. But the real complexity starts out on the fingers, in the extensor hood.
The extensor mechanism, or hood, is this incredibly elegant, integrated system. The main extensor tendon from the forearm flattens out over the knuckle, over the MCP joint.
It becomes like a sheet.
It does. It then divides into a central slip, which attaches to the base of the middle phalanx and 2 lateral bands that run down the sides.
And this is where the intrinsic muscles, the ones in the hand, join the party.
This is where they plug in. The tendons of the lumbricals and the interossei muscles merge with those lateral bands. And then all of those combined tendons reunite at the end to form the terminal tendon, which inserts onto the very tip of the finger, the distal phalanx.
So it's a confluence of tendons from different muscles.
It's a complex web that allows for coupled movements. If you only used your long extrinsic extensors, you'd just pull your knuckles back into hyperextension, but your fingers would stay bent. The hood is what allows the small intrinsic muscles to extend the middle and end joints of your fingers.
It's the coupling device that lets you straighten your finger completely.
Precisely. It lets you stabilize the main knuckle in a slightly flexed position while actively extending the other 2 joints.
Which brings us to the intrinsic muscles themselves, the precision instruments. Let's start with the thenar group.
The thenar muscles form that fleshy mound at the base of your thumb, the thenar eminence. They are almost all supplied by the recurrent motor branch of the median nerve.
The $1,000,000 nerve.
The $1,000,000 nerve, because a tiny cut there can be so devastating. This group includes the abductor pollicis brevis, the main thumb abductor, the flexor pollicis brevis, and the opponens pollicis.
And the opponens is the key one for opposition.
It is arguably the most crucial. Its contraction is what produces that simultaneous flexion and medial rotation of the thumb's metacarpal, pulling it across the palm to meet the fingertips.
On the other side of the hand, we have the hypothenar group for the little finger.
Right, forming the hypothenar eminence. These are all supplied by the ulnar nerve. They mirror the thumb muscles. You have an abductor digiti minimi, a flexor digiti minimi brevis, and an opponens digiti minimi.
And the opponens deepens the palm.
It rotates the 5th metacarpal and flexes it forward, which is key for that cupping action, for making a really tight grip around an object.
Now for the most biomechanically fascinating muscles in the hand, the lumbricals.
The 4 lumbricals are they're unique. They're these small worm-like muscles. And what's so strange about them is their origin and insertion. They actually arise from the sides of the deep flexor tendons, the FDP tendons, in your palm.
So they start on a flexor tendon,
And they insert onto the extensor hood on the dorsal side of the finger.
which leads to their really paradoxical action.
It does. Because of this unique path, they can do something no other muscle can. They simultaneously flex the main knuckle, the MCP joint, while extending the other 2 joints, the IP joints.
Creating that L shape with your finger.
Exactly, the intrinsic pluses position. And that posture is essential for any delicate, non-forceful movement. Writing, playing the piano, holding a sheet of paper, that's all lumbrical action.
Finally, the interossei, the muscles between the metacarpal bones.
There are 7 of them, 4 dorsal and 3 palmar. And we use a great mnemonic to remember their function, DAB and PAB.
DAB, dorsal interossei abduct.
Correct. The 4 dorsal interossi are powerful, and they are responsible for abducting the finger, spreading them apart, away from the middle finger.
And PAD, palmar interossei adduct.
The 3 palmar interossi pull the fingers back together toward the middle finger. Both sets are absolutely critical for stabilizing the fingers during a lateral pinch, like when you hold a key, and they are all supplied by the deep branch of the ulnar nerve.
So from a clinical standpoint, testing finger spreading is a great way to test the ulnar nerve.
It's the classic test. You ask the person to spread their fingers wide against resistance. If they can't, it points to a significant ulnar nerve problem because that nerve powers all of these crucial intrinsic muscles.
All of these muscles have to work together perfectly, which leads us to the difference between a power grip and a precision grip.
It's all about movement coordination. The agonist muscles fire, the antagonists relax, the synergists stabilize. The power grip is for maximum force, like holding a hammer.
And that involves the big extrinsic muscles.
The FDS and FDP contracting hard. But biomechanically, it requires one other crucial thing. The wrist has to be held in slight extension.
Why is that?
That position slightly stretches the long forearm flexors, putting them at their optimal length on the length tension curve. It's the position where they can generate the absolute maximum amount of force. Try squeezing your fist hard with your wrist fully flexed. You can't.
You're right, it's much weaker. The precision grip is a different story.
A completely different story. It relies almost entirely on the thumb's opposition, driven by those median nerve-powered lumbar muscles, combined with the incredibly subtle, regulated action of the ulnar nerve-powered lumbricals and interossae. It's for threading a needle or picking up a pin, where sensory feedback and fine positioning are everything.
A machine this complex needs a robust power grid and communication network. Let's map the supply lines, starting with the arteries. And the theme here is redundancy.
Incredible redundancy. The entire blood supply comes from the radial and ulnar arteries from the forearm. But they don't just end. They form this crucial, communicating dual arch system to ensure fail-safe circulation.
Let's follow the ulnar artery first.
The ulnar artery enters the hand through Goyen's canal. It then immediately arches across the palm to form the superficial palmar arch, or SPA.
And it's called superficial because?
It lies immediately deep to that palmar aponeurosis, but superficial to all the long flexor tendons. It's primarily formed by the ulnar artery, and then it's usually completed by a small branch from the radial artery.
And the SPA mainly supplies the fingers.
It does. It gives rise to the common palmar digital arteries, which then split to become the proper digital arteries that run up the sides of each finger.
Now, the radial artery takes a completely different, much deeper path.
A much deeper path. It curves around the back of the wrist, passing through that little depression at the base of the thumb called the anatomical snuff box.
So you can feel its pulse.
Exactly. It then dives deep between the bones of the hand to emerge in the deep palm, where it forms the deep palmar arch, or DPA.
So the DPA is way deeper than the SPA.
Much deeper. It lies right on the bases of the metacarpal bones, deep to all the long flexor tendons. It's formed mainly by the radial artery and completed by a deep branch from the ulnar artery. The DPA primarily supplies the bones and intrinsic muscles of the palm.
This raises the important question. These two arches are connected, right? This redundancy is the whole point.
It is absolutely vital. The hand is so prone to trauma. The extensive connections and anastomoses between the SPA and the DPA ensure a robust, redundant blood flow. If one of the main arteries, the radial or ulnar, gets blocked or cut, the other one can usually maintain adequate blood flow to the entire hand through this arch system.
And that's what's tested with the Allen's test before certain procedures.
That's precisely what it's testing, to make sure that collateral circulation is intact. Without this dual system, a small injury could easily lead to a dead finger.
Okay, the command lines. Innervation. 3 major nerves: median, ulnar, and radial. Let's map the median nerve's territory.
The median nerve is often called the eye of the hand because it's so important for sensation. It enters the hand, as we know, by passing straight through the carpal tunnel.
And what's its motor territory in the hand?
Its primary motor job is handled by that recurrent motor branch, which supplies the key muscles of opposition, the thenar group. It also supplies the first and second lumbricals, those precision muscles for the index and middle fingers.
And its sensory distribution?
It's the palmar surface of the thumb, index, middle, and the radial half of the ring finger, so the radial 3.5 digits. And crucially, it also supplies the very tips of those same fingers on the dorsal side, the part you use for fine touch.
Next, the ulnar nerve, the powerhouse for the intrinsic muscles.
Absolutely. It enters through Goyen's canal and immediately splits into a superficial sensory branch and a deep motor branch. That deep terminal branch is the one that arches across the palm with the DPA and supplies the vast majority of the hand's intrinsic muscles.
Which ones, specifically?
All the hypothenor muscles, all 7 interossei, the 3rd and 4th lumbricals, and the adductor pollicis. The ulnar nerve essentially controls all fine finger spreading and closing and powerful pinching.
Its sensory territory is the other side of the hand.
The ulnar 1.5 digits, the little finger and the ulnar half of the ring finger, and it supplies both the palmar and dorsal aspects of that territory.
Finally, the radial nerve. It does almost nothing motor-wise in the hand itself.
Correct. Its motor work is all done in the forearm, extending the wrist and fingers. In the hand, its role is almost purely sensory. Its dorsal digital branches supply sensation to the skin on the back, the dorsum of the hand.
Over which digits?
Over the radial 3.5 digits. But, and this is a key distinction, it usually only supplies the skin over the proximal parts of those fingers. The highly sensitive dorsal fingertips are taken over by the median and ulnar nerves, reflecting the priority of tactile feedback at the working end of the digit.
Understanding these pathways gives you a perfect diagnostic map. So let's quickly contrast the two big compression syndromes at the wrist. Carpal tunnel syndrome, revisited.
We know it's median nerve compression. Early symptoms are sensory, tingling in those radial 3.5 digits, often waking you up at night. The late ominous sign is the narwhal sting, that visible flattening of the thumb pad because the muscles are paralyzed and atrophying.
Compared to ulnar nerve compression in Guyon's canal.
A totally different picture. Ulnar compression leads to profound motor deficits first. Marked weakness in all the interossei, so you can't spread or close your fingers well, weakness in the hypothenar muscles. And if it's chronic, you get that characteristic claw hand deformity, especially in the 4th and 5th fingers, because the intrinsic muscles are knocked out and the extrinsic muscles pull the joints into that clawed position.
And the sensory loss is confined to the ulnar 1.5 digits.
Confined and clear. It's a beautiful example of how anatomy dictates clinical presentation.
This deep dive has just been. It's revealed the wrist and hand as this absolute masterclass in leveraged mechanical efficiency. We've systematically gone through every layer.
We started with that protective superficial envelope, the specialized palmar skin, and then saw how the deep fascia creates these rigid canals, the carpal and Guyon's, and these crucial compartments that manage force and infection.
Then we explored the osseous framework. The 8 dynamic carpals, the critical load distribution, and that unique saddle joint of the thumb that makes us human.
And we broke down the sophisticated engine, the difference between the powerful extrinsic flexors, which are useless without that A2-A4 pulley system, and the precision-focused intrinsics, all integrated by that elegant extensor herd.
And finally, we mapped the supply network. The vascular failsafe of the dual palmar arches and the command lines of the median, ulnar, and radial nerves, where just a few millimeters of compression can paralyze an entire functional group.
And this depth of knowledge is so important because it reminds you that the hand is a model of interdependence. Every single element, from a tiny fibrous pulley to the rotational stability of the carpal rows, has to work in perfect sync.
It's just astonishing. 27 bones, 3 major nerves, 2 major arteries, 18 intrinsic muscles, all operating as a single, dynamically adjustable mechanical linkage.
When you consider that density and that complexity, the most surprising realization isn't how often things go wrong, it's how perfectly they work together automatically for a lifetime of movement and exploration.
So our final provocative thought for you to consider. Take a moment. Think about the simple act of turning a key in a lock. Just that one motion. Realize the immense coordination. The power grip has to stabilize the wrist, the pulleys have to hold the tendons taut, the interossei have to hold the fingers steady, the lumbricals position the fingertips, the thumb provides the rotational force.
All while the digital nerves are providing constant, perfect feedback on the key's resistance.
And all of this happens without a single conscious command. That right there is the magic of this machine.